Hello, I'm Dr. Cessna, and I want to welcome you to the second session of a two-part blood presentation on the interpretation and application of nutritional therapy. This blood interpretation study is the seventh session of the Chiropractic Family Practice, Nutrition, and Diagnostic Preventive Medicine course. In this second blood study session, we are going to detail the germane features that comprise the essentials of interpretation of the special blood chemistries and tumor markers employed in a clinical setting. In addition, we'll review briefly the salient facts of the tests that comprise the multi-channel chemistry, the thyroid profile, and the CBC with differential that was previously presented in Session 6. As we emphasized in Session 6, when you consider the simplicity of blood analysis procedures and factor the relative low cost of blood tests to the abundance of patient clinical data that it provides, without question, compared to other diagnostic methods, blood studies are the most valuable diagnostic modality that a physician can employ. It is well to keep in mind that the body in its magnificent intelligence and unending endeavor to maintain homeostasis is in a constant but minute flux, as it attempts to alter and adjust the many components that makes up the blood plasma. Of course, changes must also occur in the solid elements as well, such as cell-mediated immunological modulations and the changes seen in the elevation and depression of white blood cells, red blood cells, and the platelets. When you observe a test result, you must remember that the number you are observing may be in a state of continuous change. That is, it is either increasing, decreasing, or it may be holding fairly constant. This slide image demonstrates three separate tests. Note that on day 5, all three of the tests are the same value at 20 and within the clinical range. Yet, the test in blue is rapidly decreasing from high outside the clinical range at 37 on day 1 to as low as 6.5 on day 9, and again outside the clinical range. Let's look at the test in white. On day 1 it reads 10 and rapidly elevates to 20 on day 5, with a marked increase above the clinical range at 30 on day 9. Finally, note the test in red is rather stable, but the line is not perfectly level, as it varies only slightly throughout the 9 days between 22 and 19. Blood values do not remain unchanged for very long. This is especially true when there is a major assault on the host, as seen in systemic infections, malignant disease, toxic states, some allergic insults, and other portentous disorders. Certainly, it's important to keep in mind that the interpretation of blood results should only be initiated on current or recent tests. As a general rule, they should never be over 6 weeks old, with less than 4 weeks preferred. Of course, rapid changes as seen in infections should be limited to 4 or 5 days to a week, and sometimes less than that. Before we introduce you to the many associated clinical blood chemistries, we are going to review the germane elements of the multi-channel 24, thyroid panel, and CBC with differential, as presented previously in Session 6. Certainly all the material presented in Session 6 is important. However, the following review will present the salient facts that you should commit to memory as you begin to read and continue to interpret the blood panels. You will soon find that by mere repetition, this learning process will come easy, and you will begin to memorize the essential points of blood analysis. First is cholesterol. Certainly, it should never exceed 200 or be less than 120. And remember, less than 140 can be an ominous sign. When cholesterol is high, think hyperlipidemia or diabetes mellitus. An underactive thyroid results in a sluggish metabolism. Thus, the cholesterol is poorly utilized and will accumulate in the plasma. When cholesterol is decreased, your thoughts should be directed to liver disease, as the liver manufactures cholesterol. Of course, acute infections stress the liver and the cholesterol drops, which is also seen in malignancies and other chronic diseases. An increase in metabolism that occurs in hyperthyroidism will also drive down cholesterol. Triglycerides are primarily utilized by the nervous system. When increased, they are commonly associated with a high cholesterol and hyperlipidemia. Keep in mind that chronic pancreatitis should be suspected when triglycerides are greater than 500. A decreased value of triglycerides is not too significant. Glucose is concerned with carbohydrate metabolism and should not exceed 115 or be less than 70. Diabetes mellitus should come to mind when increased. Also check the thyroid panel for hyperthyroidism and the blood urea nitrogen and creatinine for a possible chronic nephritis. Remember to monitor diabetics under therapy with glycohemoglobin A1C. Liver destruction greatly impairs sugar metabolism, resulting in a low glucose. Very low values are seen in hyperinsulinism, and the cause must be revealed. Certainly, hypothyroid states can produce a decreased blood sugar as well. Sodium should be kept between 135 and 145. Sodium is excreted by the kidneys, thus renal disorders can interfere with its elimination, and the sodium elevates in the blood. Sodium is influenced by the adrenals, which will increase sodium in hypercorticoadrenalism. Conditions which result in a loss of sodium, such as dehydration and diarrhea, or disorders of metabolism as seen in acidosis and myxedema, will exhibit low serum sodium. Of course, a decreased sodium is classic in Addison's disease or Addison syndrome. Potassium is essentially intracellular. Ideally, serum potassium should never be less than 4.0, although some labs indicate expected levels as low as 3.0. Believe me, this is very bad. Even 3.5 is not good. When the serum potassium is that low, the intracellular value has to be low as well. Keep the potassium above 4.0 if possible, as it's exceedingly vital to heart muscle function. Potassium will increase with acidosis and when there is diarrhea. Infections and some nephropathies will elevate potassium, and of course, as sodium is typically low in Addison's disorders, potassium is classically high. Potassium is lost in nephritis and is rapidly excreted by many diuretics. Malignancies are notorious for low intracellular potassium, as well as a depressed serum potassium. Potassium will be decreased in anemia and diabetes. A very severe acute diarrhea with several discharges each day will result in a low serum potassium. When the chloride is increased, first think of obstructive nephropathies and check the BUN and creatinine. The next most common cause is anemia, so look at the hemopoietic factors. Dehydration will elevate chlorides. States of acidosis will decrease chloride in addition to diarrhea and when there is an acute infection. Carbon dioxide is simple. When high, it's alkalosis. When low, it's acidosis. CO2 bicarbonate greater than 32 strongly suggests disturbed lung function and respiratory disease. Decreased CO2 is seen in metabolic acidosis, such as diabetes mellitus and nephropathies. It will also be depressed with diarrhea and after severe exercise. The range of blood urea nitrogen should be between 10 and 26. When you hear BUN, think kidney when high and liver when low. BUN is excreted by the kidneys, and when they are in trouble and fail to eliminate adequately, the BUN accumulates in the plasma. BUN results from the separation of nitrogen from protein in the liver. When the liver is ill or overworked by chronic wasting diseases and unable to perform this duty adequately, the amount of BUN is reduced, and this is reflected as a low BUN value in the plasma. From a diagnostic point of view, creatinine is much like BUN, as it must be eliminated by the kidney. Therefore, any kidney dysfunction that results in urinary obstruction will increase serum creatinine. Increased thyroid metabolism, that is hyperthyroidism, will increase creatinine as well. Other than a myotonia congenita in the young, decreased creatinine is of little concern. When the BUN creatinine ratio is high, think too much protein, either from the diet or a breakdown of tissue, as in catabolic states such as fever, tissue trauma, internal bleeding, dehydration, or a fall in renal blood flow and renal obstruction or renal failure. As the BUN creatinine ratio drops, the opposite occurs and low protein manifestation should be considered. This may be due to diet, or it can occur in pregnancy as a result of an increase in blood volume. Conditions of overhydration will lower the BUN creatinine ratio, as in an inappropriate secretion of the antidiuretic hormone, or simply drinking too much water prior to the blood draw. When we hear uric acid, most of us think of gout. Of course, there are other etiologies to consider. Simply stated, uric acid is the ash or waste of protein metabolism. When serum uric acid is greater than 8 milligrams per deciliter, there's either too much protein being burned or the ashes are not being liquidated adequately by the kidneys. A metabolic increase is seen in gout, diabetes, and anemia. Urinary obstructions, as in nephritis, will elevate serum uric acid. If protein intake is low, or the protein available is not being processed efficiently, then the ashes of protein digestion will be depressed, resulting in a low serum uric acid. This can be due to poor enzymation, a decrease in hydrochloric acid, or a decrease in pepsin. Many people exhibit less than ideal amounts of calcium. Thus, the low clinical range at 8.5, typical of most reference labs. Ideal serum value should be much higher, about 9.7. As pointed out in Session 6, often the calcium is low because of a deficient phosphorus, and thus a low calcium phosphorus index, rather than a dietary calcium deficiency. A pathological increase in serum calcium can result from mobilizing calcium from bone, as seen in an excess intake of vitamin D, bone carcinoma, multiple myeloma, and in hyperparathyroid states. The most common cause for a decreased serum calcium is a lack of adequate vitamin D and calcium. Of course, a person who is malnourished will be calcium deficient. Often, calcium is lost as a result of a disease process like osteomalacia, diarrhea, hypoparathyroidism, in kidney disease such as nephritis and nephrosis, and in pneumonia. Although not a disease, calcium is also lost in pregnancy. I hope that after taking this course of instruction, the first thing you will do when you observe a serum phosphorus value is calculate the calcium phosphorus index. This is done by squaring the serum phosphorus and then multiply this figure by 2.5. It should be equal to or greater than 30. Serum phosphorus will be increased if there is an excess intake of vitamin D, or fail to be eliminated by the kidneys in renal insufficiency and nephritis. Phosphorus also elevates during the healing of fractures and in hypoparathyroidism. Pathologically decreased phosphorus occurs in hyperparathyroidism, osteomalacia, and myxedema. When you see a calcium-albumin ratio, think just one thing. If it's over 2.7, it's bad news. An elevated ratio is one of the 4 ominous signs and reveals there is a protein deficiency due to malnutrition or there is a visceral protein loss. With the correct therapy, often nutritional, it can be reversed. It is a very serious finding and, of course, must be corrected.